Periodontitis and dental bone loss, a comprehensive overview. Introduction, Understanding and Treating Dental Bone Loss. Dental bone loss is a significant and often silently progressing condition that refers to the deterioration of the jawbone supporting our teeth. When this bone loss is observed in conjunction with persistent bad breath, it's a strong indicator of periodontitis, an advanced and serious form of gum disease. Caused primarily by bacterial infection, if left unaddressed, periodontitis can lead to more than just bad breath and sensitive gums. It can result in tooth loss, alterations in facial structure, and a cascade of other notable oral and systemic health issues. This comprehensive informational overview aims to demystify periodontitis, providing a clear understanding of its nature and impact. We'll delve into the precise mechanisms by which this disease takes hold, exploring its key causes and how the body's own immune response inadvertently contributes to bone destruction. You'll learn to recognize the common symptoms, understand the thorough diagnostic process dentists and periodontists employ, and discover the multifaceted treatment options available, from non-surgical deep cleanings to advanced surgical procedures like bone grafting and guided tissue regeneration. Crucially, we'll also highlight the profound connections between periodontal health and overall systemic well-being, emphasizing why treating gum disease is vital for your entire body. Finally, we'll discuss the essential role of long-term maintenance in preventing recurrence and preserving your oral health for years to come. What is periodontitis? Periodontitis is a chronic inflammatory disease initiated by bacterial plaque accumulation beneath the gum line. Unlike gingivitis, which involves gum inflammation without bone involvement, periodontitis leads to the progressive destruction of the soft tissues and, critically, the alveolar bone that anchors teeth. This weakening of foundational support compromises tooth stability and facial structural integrity. The bacteria thriving in the deep pockets formed by gum and bone destruction produce foul-smelling gases, which cause the persistent bad breath often associated with the condition. In a healthy mouth, gum tissue fits snugly around the tooth, forming a shallow, protective space. In periodontitis, this space deepens, creating a pocket where bacteria can hide and flourish, inaccessible to typical oral hygiene practices. This environment fosters bacterial growth, leading to the unpleasant odors characteristic of the disease. Beyond oral health, systemic connections of periodontitis. The impact of periodontitis extends beyond the mouth. The bacteria and inflammatory mediators, chemicals released by the body's immune response, from periodontal disease can enter the bloodstream and travel to other parts of the body, potentially contributing to or exacerbating various systemic conditions. Understanding these connections highlights the broader importance of managing periodontal health. Common oral health consequences. Tooth loss and shifting. As the bone and supporting structures are destroyed, teeth can become loose, shift out of alignment, or even fall out. This often leads to difficulties with chewing and speaking. Changes in bite. Occlusion. Shifting teeth can alter how upper and lower teeth meet, potentially causing discomfort, jaw pain, and increased wear on certain teeth. Increased sensitivity. Gum recession, often a consequence of periodontitis, can expose the tooth roots, leading to sensitivity to hot, cold, or sweet foods and drinks. Recurrent abscesses. Deep, infected pockets can develop into painful abscesses, which require immediate dental attention. Impact on dental prosthetics. For individuals with existing dental work like bridges, crowns, or dentures, the progression of periodontitis can undermine the stability and longevity of these restorations, leading to their failure or poor fit. Systemic health connections. Cardiovascular disease. Periodontitis is associated with an increased risk of serious cardiovascular problems, including heart attack, stroke, and other conditions affecting the heart and blood vessels. The inflammation in the gums may contribute to inflammation and hardening of the arteries, atherosclerosis, throughout the body. Diabetes. A significant two-way relationship exists between periodontitis and diabetes. Periodontitis can make it more challenging for individuals with diabetes to control their blood sugar levels, and conversely, poorly controlled diabetes can worsen periodontal disease, creating a vicious cycle. Respiratory diseases. Oral bacteria from infected gums can be inhaled into the lungs. This aspiration of bacteria may contribute to respiratory infections such as pneumonia, bronchitis, and can exacerbate conditions like chronic obstructive pulmonary disease, COPD. Adverse pregnancy outcomes. In pregnant individuals, periodontitis has been linked to an increased risk of preterm birth and babies born with low birth weight. Kidney disease. Chronic inflammation originating from periodontitis may play a role in the progression of kidney disease. Rheumatoid arthritis. Individuals with rheumatoid arthritis often show a higher prevalence and severity of periodontitis. Evidence suggests that effective treatment of gum disease can help reduce inflammatory markers associated with rheumatoid arthritis. Certain cancers. Some research indicates a potential association between chronic periodontal disease and an increased risk of developing certain types of cancer, though more extensive research is ongoing to fully understand this complex relationship. Cognitive decline/dementia. Emerging studies suggest a possible link between chronic periodontal disease and an increased risk of cognitive decline and neurodegenerative conditions like Alzheimer's disease. This potential connection may be related to inflammation or bacterial byproducts affecting brain health. Key causes of dental bone loss in periodontitis. The primary cause of bone loss in periodontitis is the body's inflammatory response to the bacterial infection. While other factors can contribute to bone loss, such as unreplaced missing teeth, trauma, or systemic conditions like osteoporosis, the combination of bone loss and persistent bad breath strongly points to active periodontitis. Contributing factors to the progression of periodontitis include bacterial plaque and tartar. These are the main culprits, harboring vast colonies of harmful bacteria. Poor oral hygiene, inadequate brushing, flossing, and infrequent professional cleanings allow bacterial buildup. Smoking and tobacco use. These significantly increase the risk and severity of periodontitis, impairing the body's healing capabilities. Genetics. Some individuals possess a genetic predisposition to developing periodontitis. Systemic diseases. Conditions like diabetes, autoimmune disorders, and cardiovascular disease can worsen periodontitis. Certain medications. Some drugs can cause dry mouth, which reduces the protective effects of saliva. Stress. This can weaken the immune system, making the body more susceptible to infection. Crucially, bacteria are the primary and most direct cause of bone loss in periodontitis. These bacteria form complex communities known as biofilms, plaque and tartar, on tooth surfaces. They produce toxins and enzymes that trigger a chronic inflammatory response in the body. It is this sustained inflammation, a misguided attempt by the immune system to combat the infection, that leads to the destruction of the periodontal ligament and the resorption, breakdown, of the alveolar bone. The bone loss is essentially collateral damage resulting from the body's prolonged battle against the persistent bacterial biofilm. Recognizing the symptoms of periodontitis. Periodontitis often progresses silently in its early stages. However, as it advances, common indicators may include persistent bad breath, halitosis, a key indicator due to odor-producing bacteria in deep pockets. Receding gums, making teeth appear longer. Loose or shifting teeth. Red, swollen, or bleeding gums. Deep pockets forming between teeth and gums. Pus between teeth and gums. Difficulty chewing or biting. Changes in bite alignment or how teeth fit together. Changes in facial appearance, such as sunken features around the mouth. Denture discomfort due to poor fit. Jaw pain or stiffness. New gaps or spaces between teeth. Diagnosis of periodontitis. Accurate diagnosis necessitates a thorough examination by a dentist or periodontist, a gum specialist, which typically involves medical and dental history review, to identify relevant systemic health conditions and habits. Visual examination, checking for visible signs of gum inflammation, redness, and swelling. Plaque and tartar, calcified biofilm, are directly observed or detected, confirming the presence of bacterial communities. Periodontal probing, a critical measurement of pocket depths, the space between the tooth and gum, around each tooth. Pockets deeper than 3 mm often indicate periodontitis, as these depths create areas that are impossible to clean effectively, serving as ideal environments for harmful bacterial biofilms. Dental X-rays, these visualize underlying bone levels and assess the extent and pattern of bone loss around the teeth. Visible bone loss on X-rays is a definitive sign of an active, biofilm-driven infection. Important note about X-rays: standard dental X-rays are two-dimensional images of three-dimensional structures. They are effective for showing overall bone height and horizontal bone loss but have limitations in depicting the complex, 3D shapes of vertical, intrabony, bone defects, such as craters, on the buccal, cheek, or lingual, tongue, sides of teeth. What may appear as minor or no bone loss on a 2D X-ray can, in reality, be a significant, unmaintainable vertical defect due to the superimposition of bone or unfavorable angulation during imaging. This limitation underscores why periodontists rely heavily on tactile sensation, probing, during the examination. If there is uncertainty regarding 2D X-ray findings, particularly when clinical observations suggest deeper issues, a 3D X-ray, known as a CBCT scan, may be recommended. This scan provides a detailed 3D image of the jawbone, capable of showing bone loss and defects with high precision, aiding in a more definitive diagnosis. Assessment of tooth mobility, checking for any loosening of teeth, which indicates compromised bone support. Bleeding on probing, BOP gums that bleed easily upon gentle probing are a direct sign of active inflammation caused by bacterial presence. Comprehensive treatment for periodontitis. Treating periodontitis involves a multifaceted approach aimed at controlling the infection, halting further bone loss, and, where possible, regenerating lost tissue and bone. The specific treatment plan is tailored to the severity of the disease and individual patient needs. Non-surgical treatments, for mild to moderate periodontitis, and as initial therapy for all cases, these are typically the initial steps to control bacterial infection and inflammation. Oral hygiene instruction and education, this forms the fundamental basis of all periodontitis treatment. Patients receive instruction on effective brushing, flossing, and the use of interdental brushes or water flossers to meticulously clean between teeth and below the gum line. Scaling and root planing, SRP, deep cleaning, performed under local anesthesia. This procedure involves scaling, thoroughly removing plaque and hardened tartar, calculus, from above and below the gum line. This is the primary method for mechanically removing the bacterial biofilm. Root planing, smoothing the rough surfaces of the tooth roots to remove embedded toxins and make it more difficult for new plaque to adhere, allowing gums to reattach more firmly. Adjunctive antibiotic therapy, when indicated in some cases, to enhance the effectiveness of mechanical therapy, antibiotics may be used. These are typically not standalone treatments but are employed to target bacteria that remain after scaling and root planing. Topical, local, antibiotics, gels, chips, or strips containing antibiotics, e.g., doxycycline, minocycline, can be placed directly into deep periodontal pockets after SRP to provide sustained drug release at the site of infection. Systemic, oral, antibiotics, e.g., metronidazole, amoxicillin, tetracyclines, may be prescribed for short courses, particularly in cases of aggressive periodontitis, acute infections, or when local therapy has been insufficient. The decision for systemic antibiotics involves careful consideration of the patient's overall health and the risk of antibiotic resistance. Two, surgical treatments. For moderate to advanced periodontitis, if non-surgical treatments prove insufficient, surgical procedures, often performed by a periodontist, are employed to address deeper infection and structural damage. Sedation options are frequently available to enhance patient comfort during these procedures. Flap surgery, pocket reduction surgery/osseous surgery. This procedure involves gently lifting the gum tissue, flap, away from the teeth and underlying bone. Direct access for comprehensive cleaning. This provides the periodontist with direct, unobstructed visual and instrument access to meticulously remove all plaque, tartar, bacterial biofilm and diseased tissue from the root surfaces and the inner lining of the deep pockets. This mechanical removal is paramount, as antibiotics alone cannot eliminate these physical deposits. Osseous reshaping. This is a key component of osseous surgery. The periodontist reshapes and smooths irregular bone contours, craters, or defects created by periodontitis. These irregularities can act as bacterial traps that are impossible to clean effectively at home. By reshaping the bone, the periodontist creates a more even, healthy bone architecture that discourages bacterial recolonization and significantly reduces pocket depth. The gum tissue is then sutured back into place, often at a lower, healthier level. As a result of reducing pocket depth, the gum line may appear slightly lower after healing. This is an expected outcome that helps create a healthier, more maintainable environment, even if it exposes a small portion of the tooth surface. Soft tissue grafts, gum grafts. These are used to address gum recession caused by periodontitis, which exposes tooth roots. Tissue, from the patient's palate or a donor source, is transplanted to cover exposed roots, reduce sensitivity, prevent further recession, and improve aesthetics. Bone grafting. When significant bone has been lost, bone grafting rebuilds the jawbone. Grafting materials, autogenous, allograft, xenograft, or synthetic, act as a scaffold, stimulating the body's natural bone regeneration process. This stabilizes loose teeth and can create a stable foundation for dental implants. Guided tissue regeneration, GTR. Often combined with bone grafting, GTR involves placing a special barrier membrane between the gum tissue and the bone defect. This membrane prevents faster-growing gum cells from filling the space, allowing slower-growing bone cells to regenerate and fill the defect. Dental implants. If teeth are lost due to severe periodontitis, dental implants serve as an excellent replacement option. The implant fixture, surgically placed into the jawbone, stimulates the bone, helping to prevent further loss, and provides a durable foundation for a prosthetic tooth. Why osseous surgery is recommended over antibiotics alone. A common inquiry pertains to why osseous surgery might be recommended for persistent deep pockets instead of relying solely on antibiotic therapy, despite bacteria being the primary cause. The rationale lies in the unique challenges posed by bacterial biofilms and the structural damage inherent in periodontitis. The biofilm problem. Periodontitis-causing bacteria reside in highly organized, sticky communities called biofilms, plaque and tartar. Bacteria within these biofilms exhibit significantly higher resistance to antibiotics, often 100 to 1,000 times greater, compared to free-floating bacteria. The biofilm's protective matrix acts as a barrier, and bacteria within it display altered metabolism and genetic exchange, all contributing to this resistance. Hardened calculus further shields these bacteria. Antibiotics cannot remove structural barriers. Antibiotics cannot physically remove calcified tartar, nor can they reshape the irregular bone defects, craters, ledges, that serve as bacterial traps. These physical obstacles prevent effective mechanical cleaning and allow biofilms to persist. Antibiotics do not eliminate pockets, while antibiotics can temporarily suppress bacterial populations, they do not physically reduce the deep periodontal pockets themselves. As long as these deep, uncleanable pockets exist, bacteria will inevitably recolonize, and the disease will recur. Osseous surgery for mechanical and structural correction. Osseous surgery provides direct visual and instrument access to thoroughly remove biofilms and calculus from root surfaces. Crucially, it reshapes the underlying bone to eliminate bacterial traps and reduce pocket depths to a maintainable level, typically 3 mm or less. This physical alteration creates an environment where the area can be effectively cleaned through daily oral hygiene and professional maintenance, thereby truly halting disease progression. Antibiotic resistance concerns. Over-reliance on systemic antibiotics for chronic conditions like periodontitis contributes to the global public health issue of antibiotic resistance, potentially rendering them less effective when truly needed for other infections. Therefore, for established periodontitis, mechanical disruption, via SRP or surgery, is the indispensable core of treatment. Antibiotics are valuable as adjuncts, supplements, to mechanical therapy, used to enhance bacterial reduction, particularly in aggressive forms of the disease, or to help prevent post-surgical infection. Their efficacy is maximized when the bulk of the biofilm has been physically disrupted. The staged approach, deep cleaning first, then surgery recommendation. The progression from deep cleaning, SRP, to a recommendation for osseous surgery is a standard and appropriate clinical sequence. This reflects a phased approach to periodontal therapy. Initial assessment and non-surgical therapy. Dentists typically begin with SRP and oral hygiene instructions. Although initial probing may indicate deep pockets, the goals of this phase are to reduce the initial bacterial load and inflammation, to allow the gum tissue to heal and naturally shrink. Swelling and inflammation can make pockets appear deeper than their true, underlying depth. To assess the patient's healing capacity and commitment to home care. The crucial reevaluation. After a healing period, typically 4 to 8 weeks post-SRP, the dentist reevaluates the gum health through reprobing pockets and checking for signs of inflammation. Identifying persistent issues. If, after thorough SRP and diligent home care, certain pockets remain consistently deep, e.g., 5 mm or more, it indicates that the SRP, despite its thoroughness, could not adequately clean the very bottom of that pocket. There is likely an underlying anatomical problem, such as an irregular bone defect, preventing the gum from reattaching at a healthy, shallow level. Why might immediate, broad-spectrum antibiotic use not be the standard approach right after deep cleaning? While adjunctive antibiotics can be utilized alongside or immediately following SRP in certain situations, as described in the non-surgical treatments section, a period of reevaluation, typically 4 to 8 weeks post-SRP, is generally preferred before committing to further, broader antibiotic regimens or considering surgery. This allows the dental professional to accurately assess the effectiveness of the initial mechanical therapy alone. The initial healing phase after SRP is crucial for natural pocket reduction, and administering systemic antibiotics when the underlying anatomical problem, deep pocket, bone defect, calcified biofilm, persists may only offer temporary bacterial suppression, not a lasting solution, and contributes to the broader issue of antibiotic resistance. The strategic approach prioritizes addressing the structural issues, via surgery if indicated, after SRP and the initial healing period, which then makes any subsequent antibiotic therapy, if deemed necessary, far more effective and targeted. Determining necessity for surgery. Only at this reevaluation stage can the dentist accurately identify which pockets truly remain too deep and cannot be managed non-surgically. This ensures that surgery is only recommended when it is genuinely necessary to address these persistent, unmaintainable areas and prevent continued disease progression. Success and complications of osseous surgery. Osseous surgery is considered a highly effective and predictable procedure when performed on appropriate cases and followed by diligent patient compliance. Success in pocket reduction, while not resulting in a complete elimination of pocket depth in all cases, due to anatomical and biological limitations, osseous surgery consistently achieves significant reductions in pocket depth. Often, over 90 to 95% of treated sites are reduced to maintainable depths, typically 3 mm or less. This renders the areas cleanable and halts the disease progression. Success in preventing progression, tooth retention. This represents the primary long-term goal. Numerous long-term studies, spanning 5-20+ years, demonstrate that for individuals undergoing osseous surgery and diligently adhering to a recommended supportive periodontal maintenance program, typically every 3 to 4 months, tooth retention rates are very high, often ranging from 85% to 95% over 10 to 20 years or more. This translates to very low annual tooth loss rates, frequently less than 1 tooth per patient per year, and often as low as 0.1 to 0.2 teeth per patient per year, directly attributable to periodontitis. This contrasts sharply with the significantly higher and often rapid rates of tooth loss observed in untreated or poorly managed periodontitis. Possible complications. While generally safe, as with any surgical procedure, potential complications can arise. Common post-surgical effects: temporary tooth sensitivity, common due to root exposure, mild gum recession, an expected outcome for pocket reduction, temporary discomfort, swelling, and minor bleeding. Less common complications, indicating potential issue: persistent infection, continued bone loss, if the disease is not controlled post-surgically, lack of significant pocket reduction, increased tooth mobility, root decay due to exposed root surfaces, persistent hypersensitivity, or, very rarely, nerve damage. Regaining lost gum tissue, periodontal plastic surgery. The understanding that, if the gum is inappropriately cut off, there's no way to grow it back, is largely accurate in the sense that specialized gum tissue does not spontaneously regenerate to its original height after resective procedures. However, modern periodontal plastic surgery offers highly effective solutions to address gum recession. How it works: adding or moving tissue through further surgeries. These are distinct surgical procedures performed by a periodontist, separate from initial osseous surgery. Their aim is to cover exposed roots or increase gum tissue volume. Grafting procedures: adding tissue. Connective tissue graft, CTG, considered the gold standard. A thin piece of connective tissue is harvested from under the surface of the palate and transplanted to the receded site, tucked under existing gum. Success rates for mean root coverage often range from 85% to 98%, with complete root coverage observed in a high percentage of favorable cases. Free gingival graft, FGG. A piece of surface gum tissue is taken from the palate and directly grafted to the receded area, primarily to increase the band of attached gingiva. While highly successful for increasing gum thickness, root coverage predictability can vary. Allograft, acellular dermal matrix, ADM. This utilizes processed donated human tissue as a scaffold, avoiding a second surgical site for tissue harvest. Mean root coverage rates are comparable to CTGs, often 85 to 95%, although long-term stability can vary. Flap procedures, moving existing tissue. Coronally advanced flap, CAF. Existing gum tissue adjacent to the recession is carefully loosened and gently pulled upwards to cover the exposed root, then sutured in place. This is often combined with CTG for enhanced predictability and root coverage, mean root coverage often 90% plus. Laterally displaced, sliding, pedicle graft. A flap of gum tissue with its blood supply intact is moved sideways from an adjacent tooth to cover the receded area. Success of gum grafting procedures. These procedures demonstrate a high success rate in achieving significant root coverage and improving gum health, often providing 85% to 98% mean root coverage depending on the specific technique and patient factors. Complete root coverage is also a common outcome, particularly for certain types of defects and grafts. Success rates are influenced by the type of defect, a patient's oral hygiene, smoking status, the surgeon's skill, and overall health. Why periodontists' recommendations can differ regarding extent of surgery. It is common for two periodontists to offer differing recommendations regarding the extent of osseous surgery needed, e.g., one suggesting treatment for one quadrant versus all four. This does not necessarily imply that one opinion is incorrect, but rather highlights the complexities inherent in diagnosis and treatment planning. Interpretation of bone defects, 2D versus 3D X-rays. X-rays are 2D images. Standard dental X-rays, periapical, bite wing, are highly effective for showing bone height and horizontal bone loss. However, they are inherently limited in depicting the complex three-dimensional shapes of vertical, intrabony, bone defects, such as craters, on the buccal, cheek, or lingual, tongue, sides of teeth. What may appear as minor or no bone loss on a 2D X-ray can, in reality, be a significant, unmaintainable vertical defect due to the superimposition of bone or unfavorable angulation during imaging. This limitation underscores why periodontists rely heavily on tactile sensation, probing, during the examination. Clinical probing is paramount. While X-rays provide a snapshot of bone levels, periodontal probing remains the primary tool for detecting the true depth and configuration of these hidden 3D bone defects. If a periodontist consistently finds deep pockets, e.g., 6 mm or more, in an area where the X-ray does not show dramatic horizontal bone loss, they will strongly infer the presence of such a vertical defect. Variations in interpretation. Different periodontists may interpret these combined clinical, probing, and radiographic findings differently. One might place more emphasis on consistent deep probing depths, inferring significant underlying defects requiring surgery, even if X-rays are inconclusive. Another might take a more conservative view if radiographic evidence is not overtly clear, opting for continued close monitoring. This is also where inter-examiner variability in probing technique, e.g., the pressure applied, the angle of the probe, and the individual's tactile sensitivity, can lead to slightly different measurements and, consequently, different interpretations of the true need for surgical intervention. Treatment philosophy and thresholds. Resective versus regenerative focus. Some periodontists may lean more towards resective osseous surgery for predictable long-term pocket reduction and maintainability. Others might prioritize regenerative approaches where possible, attempting to restore lost bone. This can influence which areas they deem suitable for surgery. Action thresholds. Clinicians possess varying thresholds for when a persistent pocket definitively warrants surgical intervention. A persistent 5 mm pocket might be a definite surgical indication for one periodontist, while another might be comfortable monitoring a 5 mm pocket if there is no bleeding on probing and the patient demonstrates excellent home care. Comprehensive versus localized approach. Some periodontists prefer a comprehensive approach to treat all areas of concern simultaneously if surgery is indicated, aiming to minimize separate surgical procedures and recovery periods. Others prefer a highly localized, phased approach, treating only the most severe areas surgically and attempting to manage others conservatively. Advanced and emerging approaches. Growth factors and biologics. Techniques such as platelet-rich plasma, PRP, and platelet-rich fibrin, PRF, derived from a patient's own blood, along with bone morphogenetic proteins, BMPs, and enamel matrix derivative, EMD, are utilized to accelerate healing and enhance bone and tissue regeneration. Laser-assisted periodontal therapy, e.g., LANAP, laser-assisted new attachment procedure. This innovative approach employs specific lasers to remove infected tissue and bacteria from periodontal pockets without the need for scalpels or stitches. It is often promoted for its potential to offer less discomfort, faster recovery, and the ability to stimulate genuine tissue and bone regeneration. While it avoids traditional cutting, its effectiveness can vary depending on the individual case. Orthodontic extrusion. For localized bone defects, the gradual movement of a tooth out of its socket using orthodontic forces can stimulate the growth of new bone and gum tissue. Stem cell therapy and 3D printing. These represent cutting-edge areas of research, exploring the use of stem cells and customized 3D printed scaffolds to regenerate significant amounts of lost bone with high precision. Post-treatment and long-term maintenance, a lifelong commitment. Frequent follow-up visits are crucial after osseous surgery and bone grafting. This ongoing care, known as periodontal maintenance, or supportive periodontal therapy, SPT, is a critical component for ensuring the long-term success and stability of periodontal health following surgical intervention. Why frequent follow-up visits are crucial. Monitor healing and prevent complications. Short-term initial postoperative checks are vital for ensuring proper healing, suture removal, and addressing any immediate concerns such as persistent bleeding, excessive pain, or signs of infection. Prevent recurrence of disease. Long-term periodontitis is a chronic disease. While surgery treats its effects, the underlying susceptibility and the continued presence of bacteria mean it can recur if not consistently managed. Harmful bacteria can re-establish significant, destructive levels in periodontal pockets within approximately 9 to 11 weeks, roughly 3 months, after a professional cleaning. Periodontal maintenance, typically scheduled every 3 months, aims to disrupt these bacterial biofilms before they can mature and trigger a destructive inflammatory response again. This ongoing mechanical disruption helps prevent recurrence, stabilizes surgical outcomes, and protects the significant investment in treatment. How frequent is it then? For most patients who have undergone surgery for periodontitis, periodontal maintenance visits are generally recommended approximately every 3 months. This specific timeframe is based on scientific evidence indicating that it takes roughly this long for harmful bacteria to regrow and reach levels capable of causing damage. Therefore, maintenance visits are strategically timed to reset this process before new harm can occur. How many years are needed to maintain such frequent visits? For most individuals who have undergone surgery for periodontitis, periodontal maintenance is generally considered a lifelong commitment. Periodontitis is analogous to chronic conditions like diabetes or high blood pressure. While it can be managed effectively, the underlying predisposition and the presence of causative bacteria necessitate continuous control. Consistent, lifelong maintenance is the single most critical factor in preventing relapse, preserving remaining bone, and ensuring the long-term retention of natural teeth. Individualized frequency. While the 3-month interval is a common standard, the exact frequency can be adjusted based on individual factors such as the initial severity of periodontitis, the body's healing response, the effectiveness of daily home care, the rate of plaque and calculus buildup, and the presence of ongoing risk factors like smoking or uncontrolled diabetes. While occasional extensions to 4 months might occur for highly stable patients with excellent home care and no risk factors, extending to 6 months, like a standard general cleaning, is rare for someone with a history of moderate to severe periodontitis requiring surgery. What to expect during periodontal maintenance appointments. These visits are more extensive than routine general dental cleanings, specifically focusing on managing periodontal disease. They typically include review of medical and dental history, oral examination and comprehensive periodontal charting, remeasuring pocket depths, assessing bleeding, and noting any changes in gum recession or tooth mobility. Meticulous scaling and root planing of all tooth surfaces, both above and below the gum line. Polishing to remove surface stains. Review and reinforcement of effective oral hygiene techniques. Periodic radiographic review, as needed, to monitor bone levels over time. Conclusion. Periodontitis is a complex, chronic inflammatory disease affecting the gums and underlying bone, driven primarily by bacterial biofilms. Its impact extends beyond oral health, with established connections to various systemic conditions, underscoring the importance of its management. While dental bone loss and the need for surgical intervention can be daunting topics, modern periodontal treatments, including scaling and root planing, osseous surgery, and bone grafting, aim to control the infection, halt disease progression, and, where possible, regenerate lost tissues. A multi-phase treatment approach, often starting with non-surgical therapies before considering surgery for persistent issues, is standard practice. The effectiveness of these interventions is significantly bolstered by consistent, long-term periodontal maintenance. This ongoing professional care, typically recommended every 3 months and considered a lifelong commitment for individuals with a history of periodontitis, is crucial for preventing disease recurrence and preserving teeth. Understanding these aspects of periodontitis and its management is essential for comprehending the journey toward lasting periodontal health.